Morning, everyone. I'm Ahmed, one of the second-year fellows at the University of Cincinnati. So, acute PE is the third most common cause of cardiovascular death after MI and stroke, and is considered the leading cause of preventable death in hospitalized patients. Treatment with systemic thrombolysis is effective and decreases mortality, but it's associated with a greater risk of hemorrhagic complications. Sure.
Thank you.
So the risk of hemorrhagic complications, including 2 to 5% risk of hemorrhagic stroke. Furthermore, the lack of level 1 evidence for the safety and efficacy of catheter-directed therapy brings controversy to a promising treatment approach. Aspiration thrombectomy is now an approved option for select patients with acute massive or submassive PEs. Patients with massive pulmonary embolism may also be successfully treated by being placed on VA ECMO support. I'm going to present a case of massive PE treated with VA ECMO for obstructive shock, where aspiration thrombectomy using the penumbra indigo catheter led to hemodynamic improvement and successful decannulation from the VA ECMO support. So we had a 62-year-old male patient with a history of hypertension, diabetes, prostate, and colon cancer. He was admitted from an outside hospital with primary diagnosis of submassive bilateral PEs. 3 weeks prior to his presentation, he was seen by his PCP for dyspnea, cough, and wheezing. He was scheduled for a stress test and a CT-PA scan as an outpatient and was prescribed doxycycline and steroids. His CT revealed bilateral PEs with RV strain. He was admitted and placed on heparin drip. Due to worsening hypoxia, he was intubated afterwards. Thereafter, the patient became hemodynamically unstable and was initiated on levo, dopamine, and epinephrine. Owing to the worsening RV function and persistent hypoxia, he was transferred to our facility and placed on VA ECMO support. Repeat echo showed preserved LV function, severely reduced RV function. Repeat CTA showed bilateral PEs involving the right and left main pulmonary arteries with extension into multiple lobar and segmental branches, likely subacute in nature. On the A-line tracing, the patient had very poor pulsatility despite inotropic support, indicating very low cardiac output. And the patient failed attempted trials to wean off the ECMO support. After being on VA ECMO for 3 days and based on the persistent high clot burden, we decided to attempt aspiration thrombectomy using the penumbra catheter. Successful pulmonary artery aspiration thrombectomy was performed bilaterally using the penumbra device. Post-procedure, the patient had significantly improved pulmonary perfusion on repeat PA angiography, and signs of improved hemodynamics with markedly increased pulsatility on the arterial waveform. The patient was successfully weaned off ECMO support and was extubated shortly afterwards, and he was discharged home. So here's the image of the pre-thrombectomy PA angiography showing a very high clot burden and poor pulmonary circulation. And that's the image after the thrombectomy, showing significantly improved pulmonary circulation. The use of VA ECMO has been well documented in the setting of severe obstructive shock. However, the combination of acute and chronic thromboembolism in this case led to severe obstructive shock and RV failure. Thrombectomy allowed for immediate flow improvement in the pulmonary arterial circulation and markedly increased pulsatility, likely explained by the improved preload. So one of the initial trials to evaluate aspiration thrombectomy, they enrolled a small number of patients, 18 patients, 10 with acute submassive PE and 8 with massive PE. And they were treated with an indigo aspiration catheter for mechanical thrombectomy. 3 patients also underwent concomitant systemic fibrinolysis with TPA. Technical success was defined as successful placement of the device and initiation of the aspiration thrombectomy. Clinical success was defined as stabilization of the hemodynamic parameters, improvement in the pulmonary hypertension, RV strain, or both, and survival to hospital discharge. The procedure was considered technically successful in 17 patients and clinically successful in 15 patients. The echo showed significant improvement in the RV size, TAPSE, and S waves. 2 patients received systemic fibrinolysis. Agents experienced intracranial bleeding, and abdominal bleeding happened in 1 patient. A subsequent trial was called the Extract PE trial. And it was a prospective single-arm multicenter trial that evaluated the safety and efficacy of the indigo aspiration system in the treatment of acute PE. They enrolled 119 patients. The primary efficacy endpoint was met with significant mean reduction in the RV to LV ratio of 0.43, corresponding to a 27% reduction at 48 hours post-intervention. The primary safety endpoint was reached with a low measure adverse event composite rate of 1.7% within 2 days. The measure adverse events composite included device-related death, measure bleeding, and device-related serious adverse events. The FLAIR trial was a similar trial. They just used a different device. It's called the flow retriever system, or the inari catheter. It was a similar number of patients. And at 48 hours post-procedure, average RV to LV ratio reduction was 0.38, which is 25%. And 4 patients experienced 6 major adverse events, with 1 patient experiencing major bleeding. So in summary, aspiration thrombectomy, in addition to mechanical circulatory support, may allow for a more meaningful and successful recovery in select patients with massive PE, and they can be a safe alternative when systemic thrombolysis is contraindicated.
That was an excellent case. One of the things that we're learning at our institution as we take care of the patients with cardiogenic shock is that there's a whole other side to it. These are people coming in with obstructive shock. And we've had a PERT team now for the better part of 3 years. We started to recently incorporate the inari catheter, the flow retriever system. How does your multidisciplinary team work? Do you have commingling of your pulmonary embolism response teams and your cardiogenic shock teams? Is it the interventional cardiologists start taking these patients to the lab? Is it IR? It's very different from institution to institution. We even have vascular surgery involved, given the venous component. And then the last question I have is, what's the follow-up, given the risk that these patients may be down the road for chronic thromboembolic pulmonary hypertension?
So in our institute, it's mostly, the team is composed of critical care anesthesiology team. And if the decision is made initially for either ECOS or aspiration thrombectomy, then it involves either IR or interventional cardiology. Really depends on who's available at that time. In terms of the follow-up with chronic thromboembolic state, so for that patient, given the tremendous recovery, he got a CTPA follow-up afterwards. Of course, like long-term anticoagulation, and it showed almost complete recovery of the RV function.
Can I make a comment? I'm an interventional cardiologist in a community setting who does refer the more advanced cases to our colleagues at the Med Center. I'm here in Houston. But, we see a fair number of these patients with submassive pulmonary embolism with acute right ventricular strain. We don't have the capacity to do VA ECMO, but we definitely treat with thrombolysis, and we've sort of established a protocol of giving intrapulmonary artery thrombolysis with catheter-directed thrombolysis. You can give about half the dose as opposed to the whole 100 milligram bolus, and you give it as typically a 2 milligram TPA bolus per catheter that you just simply direct into each pulmonary artery. These are not for typically unstable patients, of course, but with RV strain and elevated troponins and so forth. We've had great success with that. I would comment about, or ask you a question about the use of concomitant thrombolysis with the ECOS catheter or with the penumbra catheter. I mean, I don't have any experience with the penumbra, but you can mix TPA in with it as you're doing the aspiration. Isn't that correct?
So typically also in our institute, so this was essentially the first case that we used, the penumbra device in that setting. Now, the ECOS is usually our go-to in selected patients, of course, upon presentation. Now, given the highly unstable hemodynamic state that the patient was at with the VA ECMO support, it was felt, and the subacute nature of the PE, I mean, he was presented after 3 weeks of complaining of those symptoms, it was thought that the yield would be low to get a meaningful improvement using the ECOS system at that time. So we decided to try
it was a fantastic outcome and a fantastic result.
Thank you.
Dr. Feldman, you had a question? So this is an obstructive disease. It requires some other intervention. The studies you presented are the ones that we've used to for indications for this particular methodology. Can you comment, Ahmed, on what would be your expectation now for this patient 6 months from now, or what all these results have actually shown regarding recovery of the right ventricle 6 months down the road as opposed to 48 hours later?
It was not, I think, designed for that long-term follow-up, and it was just an immediate recovery showing the echo parameters that I highlighted on the second study.
So that's the key here, is that in fact, unfortunately, the lines tend to blend together, and we still see progressive RV dysfunction. So at the beginning of this disease, I think you need a mechanical solution. But then thereout, I think just like when we had septal ablation, we said, oh, they're cured, we don't need to use any medicines anymore. When we've done other therapies that we've cured with steel, that we stopped being aggressive about our medical therapy. And I'm not even saying that we actually know what it should look like, but I would think that a pharmacologic plan of aggressive RV recovery to protect that heart going forward will at least be the best we have right now for a long-term outcome. Because hypothetically, just say this patient had this happen 2 weeks ago. I think the result you're looking for is not how they're going to look even at 30 days, but what does Christmas look like for this patient?
So I think you bring up a very important point. We've had a couple of patients kind of similar to what you've just described here, and we have combined not only aspiration thrombectomy, but combined ECOS thrombolysis at the end of the procedure with those. And I think the reason we have done that is mostly you can debulk a lot of the, the clot in the main PA and the bifurcation with either of these devices, whether it's Cincinnati or whether you use the Indigo penumbra catheter. But at the end of it, there's a lot of distal clot. And so you may be able to get the patient out of acute extremis, but eventually these patients deal with CTEPH in the long run. Nobody has the data to say in the long run how these devices do, but I think what we've noticed is if we end up putting ECOS catheters after you've had a successful aspiration thrombectomy, you may be able to use a lower dose of TPA than even what you would normally use if you had just done upfront only ECOS. And a lot of these candidate patients are usually not candidates for TPA, so we obviously use the combination to lower the amount of total TPA that we do. What I've typically done when I see these patients in clinic is I do serial CTs on them, usually at 48 hours, 1 month, and thereafter, and then same time I do echoes. And then usually you see the reduction in the RV to LV ratio and also the reduction in the RVSP in these patients. And again, it'll be interesting to see. Again, we don't have any good long-term data just yet, but it'll be interesting to follow all of these patients to see how much CTEPH they've developed and if there's any improvement there.
As a pulmonary hypertension-focused medical center, which I think all of us have to be, I think the most important thing is to endow the patients with responsibility because, people are mobile. And what I tell my patients after this kind of therapy, we had a big program at UCSF, we're going to have a big program at Jefferson as well, is every year you get an echo. I don't care if you're cared by a cardiologist, a pulmonologist, a neurologist, you get an echo every year. Because to the point of Wajid or someone who asked a question about long-term, I've never met one CTEPH patient, real CTEPH patient, without RV dysfunction. That RV is the mirror. The RVSP doesn't give you a lot. You can have residual elevated pressures, but if the RVSP is, mildly up and the RV shot, you got CTEPH on your hands, and you got to go after it. Even if this has been miraculously saving his life now, this guy 2 years ago could be a CTEPH patient. And the only ways to endow our patients with that, unless your PER team can take over the outpatient world as well of managing these patients.
Well, I think BQ scan should be. BQ scan is more important than follow-up CTs. And I will say this patient can have chronic thromboembolic disease without pulmonary hypertension, and that can cause also shortness of breath. So echo may not show you too many things on some of these patients coming with shortness of breath, and the BQ scan is, I think, equally as important as echocardiogram. So in centers, when a patient comes with pulmonary embolism, these patients, we are following them 3 to 6 months later with BQ scan, because that is going to give us more information in terms of chronic thromboembolic disease. So that's what we do now. Obviously, we follow them with echocardiogram, but again, it's not too much difference between chronic thromboembolic disease and pulmonary hypertension. We should be treating both of them in the same way.
Thank you. Great case, great discussion. Thank you.
Sure.